Not yet.
Okay, we're
Good.
good.
There we go.
Let's get our panel ready. We are all ready. Let's
All
keep it
right,
there.
we're ready to go. We've got a terrific panel. We've got Alain Crebier, Saibal Kar, Raj Makar, and Vinny Bapat. So we are ready. Full room. We can't wait to see this case.
Beautiful. All right. So post lunch, welcome again from the cardiac cath lab, and we go to the case number 3. Between the tower cases, we have sandwiched mitral. Okay, let's go to this case.
What's ACT?
The 81-year-old male, worsening
2000.
class 3
You gave 2000, right?
and heart failure, and most symptoms are the fatigue. Patient is on patient AFib on NOAC and was tried few medications, but some of them could not tolerate, as you see there. So one-time potassium went up and so. To limit it in terms of the guideline-directed medical therapy, we know which is very important for somebody who is echo showing the moderate to severe MR, TTE and severe MR on the TEE. Before I describe, I can we can get STEM to tag, show the live echo, please. So let's see. Okay.
Dilated, and the function is about 35%. RV function is mildly decreased, mild dilated. You can appreciate the severe mitral regurgitation. We have decreased the NACUS limit just to measure the PISA, but with all the measurements, the MR ERO comes to 0.45 centimeters square. The MR volume, the regurgitant volume is 70 ml, and the regurgitant fraction is 63%, so severe secondary mitral regurgitation. The gradient through the valve is 1 millimeter mercury. The valve area by 3D multiplanar reconstruction is 8.3 centimeters square. The pulmonary vein, the right upper pulmonary vein shows blended systolic wave of the pulmonary vein, the same in the left after pulmonary vein. This is the bicommissure view. You can appreciate a wide jet, mostly central, but wide, severe mitral regurgitation. This is a 3D phase view with the aorta on the top. And you can see again that the MR is wide, but mostly central in location. This is a true view for more rendering of the valve. This you can see again, mostly central mitral regurgitation. And this is the glass view, which you can appreciate the color better. This is, we measured the leaflet length. The posterior leaflet is 1.8 centimeter. The anterior, there's no problem, is about 3 centimeters. This is a moderate tricuspid regurgitation with a PA pressure about 35 to 40 millimeters of mercury. Thank you.
Okay, so let's go back to the slide, and I'll just end it because this is more of a CAD or non-CAD. This we already have shown. All this point for the echo, TE, transthoracic, all the very nice color and fancy pictures. The plan is to do a tier using mitral clip XTW to reduce the mitral rigor. So before we go on, and Anu is already ready for the transeptal. Yeah. So Greg, knowing our co-op trial by heart, your co-op trial, what number of the patients, what % of the patients who could not tolerate guideline-directed medical therapy more than one of the medicine in the co-op trial?
Well, very few of the patients were on, at that time there were only 3. That was before the gliflozins, but there were only 3 drugs, and very few of them were on all 3. And actually only about 15% of the patients were on maximally tolerated doses of all 3. The majority of them were on either 1 or 2 drugs. And so this is actually a pretty typical situation, either because of hypotension or renal insufficiency or a variety of other causes. GDMT is often not well tolerated in these patients. What was the basis of the cardiomyopathy here? Was this ischemic or idiopathic?
Idiopathic. It's maybe regurgitation point of view. Yeah.
Yeah, because
you're now.
Yeah, because it was fairly marked restriction of both the anterior and posterior leaflets, which is a little unusual, but it was mostly a central jet. But this is severe MR, and the LV is not too dilated, so I think this patient should respond very well to the mitral clip. Saibal, any comments? You got to get a mic, some things. Push and hold. Yeah.
Maybe you should have a transapical
Heparin? More heparin?
mitral valve replacement.
We just gave 2,000.
No, but you
I'm being sarcastic.
He's being sarcastic.
Can we-
Yeah, this should be a
Yeah, we'll do
really
a
good.
transeptal mitral valve replacement. Yeah. No. Okay.
Think, of course, it's TIA.
How much does the patient weigh?
Saibal saying do tier now and 6 months later do
91? Oh, yeah. Okay, 7 years. 7, yeah. Mm-hmm.
Raj
All right,
or,
guys,
or
let's
Vinny,
go.
any
I know.
other
I've been on a
thoughts
tidal volume
for this
increase
case? It seems pretty straightforward.
Yeah, I think this is
Tidal
the
volume.
garden variety vanilla type patient
Yeah.
of functional MR that is being treated
Yeah.
with CLIP today, right? So nice wide central jet. And patient is, I think, they've made a good attempt to treat this patient with good medical
What's your
treatment.
tidal
So
volume?
Yeah.
this is a perfect indication, I would say.
Okay, great.
What's the
Greg.
PA pressures or the RVSP?
26.
It was
Greg, I have a
14,
question.
right?
26. So
26.
absence of
36.
severe pulmonary, almost normal pulmonary pressures. Roxana, you had a question?
Yep.
I wanted you to kind of go over what what you did in COAPT and who were the patients who would fit into this kind of a thing, because I think
Sure.
our audience online would like to know.
Sure. So the patients in COAPT.
And maybe
had-
since they are ready for now, Greg and Roxana,
Yeah,
so
go
they
ahead.
are ready for the transeptal. So as soon as they are done, then we'll have enough time
Okay.
before they get to device yes, because that's a very important point which Roxana asked. Everybody wants to know
Yeah,
that.
we can do that anytime. Okay.
Yeah. What happened now? Anu, tell us. It flew by itself. What happened?
Yeah.
You can show the bicable.
You want to measure the pressure?
With the bicable and show the height.
Yeah, we saw the tenting of the intraatrial septum, and now you've got the catheter across.
I would have gone a little bit more posterior.
Yeah.
I think you were mid-fossa, bicable, but
So you want to
Yeah.
be posterior.
What's
and
our, what's our,
superior.
what's our distance? 5.2, Saibal. Saibal.
5?
5.2.
5.2 centimeter height. This is a huge atrium. If you go too posterior, you might, run out of room to go into grass.
Not with the G4, you can go up till 5, 6, it doesn't matter.
No,
Tell me the
understood. Yeah. Okay, the pressure.
Measure
Do we zero?
measure
No,
again
zero?
for Dr. Carr. Measure again for Dr. Carr.
Yeah.
5.5.
Yeah. Heparin's given?
Yep.
Okay.
So it'd be interesting if you get a chance to show us what the left atrial pressure and waveform looks like.
Yeah,
Sure.
we are going to do.
There's a lot of discussion about can you use that as looking at the acute response in the left atrial waveform as a prognostic predictor, and that's one thing we did not look at in COAPT.
Question.
push and hold.
I routinely do that in all cases.
Yeah.
I actually have a double wire and one 4 French pigtail
Mm-hmm.
and without the guide. And to me, if there's no change in LA pressure or an increase in LA pressure, that's usually a bad sign.
Right.
So an acute reduction or a change in the V wave,
Right.
one of the two, then
At
it makes...
least the V wave.
LA pressure.
So, Anu and Samin, we've, just to mention, there's
coughing.
another transeptal system called the VersaCross, which is what we are using now. It uses electric energy, but the important thing is that it's got this pre-shaped wire, which is pretty strong, and then you can advance the MitraClip guide over it, so you don't have to do any exchanges.
Okay.
Made by
Show us the
Baylis, now acquired
hemodynamics.
by Boston.
Good.
That's a radio frequency wire, correct? Yeah.
In a small community hospital, I can't afford the expensive stuff, so I just use the Bovie.
LA pressure.
Yeah.
18.
Yeah, that's it.
Okay. How is the LA pressure? About
Let's see. if you can
34?
Get us a stable waveform. I like to see how big the V wave is too.
Can we slow down the rate a little bit for us also? Heart rate. Yeah.
Right. Yeah.
Annie, why did you use a Mullen sheet? I saw you used a Mullen. You didn't use an SL0?
We use
SL1?
the
Maybe speed
size
the
of
trace.
LA and RA, large. CR also.
He looks fairly
But yeah, with
tachycardic,
large
too.
right atrium. Yeah, with a large right atrium, we typically you use the Mullins because sometimes the SL may not reach. So we've had that. We actually have 2 cases on Monday that had that experience.
so Saibal, what sheath do you use predominantly?
I just use an SL1 sheath. SL0, SL1.
Okay.
And then once I get a left atrium, and then I switch to a wire. And
Okay, I think this is about time now. Greg, you're telling about the question which Roxana asked earlier.
Yeah, so,
in the
so this
co-op-
would have been a very good patient for the co-op trial. So we took patients with either ischemic or idiopathic dilated cardiomyopathy who were either good surgical candidates or very poor surgical candidates, so surgical risk didn't factor into it, who had either 3+ or 4+ mitral regurgitation. And there was a variety of different ways that we determined that, but the easiest way to remember is either an EROA of greater than or equal to 0.3 millimeters squared or a pulmonary systolic venous flow reversal. That was about 87% of the patients in COAPT. And they had to have a left ventricular end systolic dimension less than 7 centimeters. And we did that purposely so we didn't have patients who had such
Yeah, we
severe
put it in the
LV
septum.
dysfunction that their prognosis would be dominated by the LV rather than the MR. The ejection fraction ranges were about 20 to 50%, but they probably could go higher and probably even a little bit lower as long as the LV is not too dilated. We excluded patients with very severe pulmonary hypertension, but as it turns out, we had people with PA pressures up to 100 millimeters of mercury. We excluded patients with very severe RV dysfunction and severe tricuspid regurgitation. So this would have been
Can
just
we
a
map
typical
screen,
patient.
please?
And of course, they had to be on maximally tolerated guideline-directed medical therapy and still be symptomatic. As we discussed, many of them couldn't tolerate those medications. And now there are 4. There's 4 class 1 guideline-directed medications, and that is beta blockers, ACE inhibitors, mineralocorticoid antagonists, and either EMPA or dapagliflozin. And they really should all be tried because they really make a difference.
And I remember on the calls, no one was discussing the anatomy. All that we used to discuss about is GDMT, right?
Yeah.
In case selection, people say, "Can you clip it?" Yeah.
Yes.
Okay.
Well, that was it. We left it up to
ACT
each
number?
operator
Operator.
to see if
That's
they
right.
could, if they thought they'd be able to successfully clip it.
Yeah. Discussion used to be about medications, blood pressure control.
So do
Yeah.
you routinely dilate the septum with a balloon?
We have recently started doing that. A couple of times we have had issues of crossing the septum. So just to be as a part of a step, so we keep doing
do it routinely
this
now.
step routine now. Yeah.
So,
Yeah,
there's been a
also
lot of
remember
discussion
we,
about
we-
ASDs after these procedures, right? And whether that's a good thing or a
Yes.
bad thing. And it may be that a very small ASD, with a shunt of 1.2 to 1.3, may be a good thing.
Is that
ACT is okay?
patients who have residual MR after the procedure or persistent heart failure, their shunt often remains patent. And if it's a very good result long term, you get close. So there,
257,
There's a
2 more
selection.
thousand.
Yeah.
3 more thousand, please. 3 more
There,
thousand.
there
Dr.
actually
please.
was a small randomized trial called the Mithril trial that looked at closing small shunts versus not, and it made no difference in terms of outcome. So small shunts you can certainly leave.
So we're going up with the guide. We activated it already.
Okay.
Yeah, what?
You have the wire?
Yep.
Okay.
So Anu, what's your thought about one clip versus multiple clips in this case, and where would you try to put the first clip?
I think the
Negative, right?
based on the echo, we have this way it looks. We'll likely do 2 clips, but one would be just medial to the center and one lateral to that. Hold the wire.
And do you start medial?
Yes.
Okay, the guy is coming out to the septum.
Saibo, would you try one clip and see if you can get away with one clip? Or do you see that it's a fairly broad
Dilators
jet,
across?
even though it's mainly A2P2?
Yes.
No.
A bit more.
to go in
Push
the
a bit
middle,
more,
you
you
Now
are-
the
you
guy
are
one
through.
in. But in this case, I agree with Kenny that this will most likely be a one. The only question is usually
go
in
through.
functional MR patients,
Not
I
yet.
usually
Push
use
a bit more, yeah.
NT or actually NTW. But I agree with the choice of doing XT because this is
Okay,
the
good.
posterior fluid is quite large, right? Right? It's
Yeah.
like 1.8 centimeters.
Greg, you saw, despite us dilating the septum, it was not easy. We had to do some maneuver to
Maybe
get
if
the
you
guide
didn't
across.
dilate, it would
Yeah.
be easier.
And it
I'm
is-
being sarcastic.
Yeah, it's hard to know, right? When it's going to be difficult to cross. Sometimes the septum is more fibrotic.
I think it's about the wire position. See, what I personally do is I put the wire, park the wire in the left pulmonary vein. And when you park the wire in the left pulmonary vein, the wire is perpendicular to the septum.
Walking the
And
dilator
the
out.
trajectory is very good. So, I mean, as Raj would say, we
have enough
never,
guidance?
I
Yep.
never,
Wire back.
I don't remember.
Well, initially,
ever
I think she had it.
requiring to
Initially, it
have
was in the left pulmonary vein.
Yeah. Because we don't dilate at septum. Do you?
Next.
No, I think
I
occasionally
think this is the
you,
same controversy like
I
a
would say
pre-BAV
one
in
out
the
of-
Yeah.
tower.
25 times.
It's less controversial than that.
I see.
Okay, flush, please.
So I think a little bit about XT versus NT, right? I think we were very gung-ho on XT when it first came
Keep
out for
flushing, keep
functional
flushing.
MR, and then we noticed some
Keep
little
flushing.
tears because it grabs the leaflet, but,
Keep flushing.
predisposes a little bit to tear. So we backed
Stop
off and
flushing.
we started doing NTs and
Right here.
NTWs
Right here.
in functional MR.
Actually, I analyzed.
But we are
the
using
expand
XT here,
data-
right?
Yeah.
Any
I think it's
reason
okay.
for,
I analyzed the expand
okay?
data for leaflet injury, and it was actually not
I see.
that bad. It was not that was like very controversial. So I think it's reasonable. In
Blue to
the
blue.
expand registry, there was slightly higher percentage use of NT NTW in functional MR.
Right.
It was
so let's find out from Gilbert and Anu, why did they select XTW?
Well, the leaflets here are long, as Saibal mentioned, and
Yeah.
there's some data now that actually MitraClip has an indirect annuloplasty effect. Actually,
coming
Stefan
back.
in Mainz has shown some of that work. So we feel that there's some additional ancillary benefit if you use the large could increase the coaptation depth, actually.
You have to get the guide back.
Yeah, we really need
yeah.
better data
We're
on
pulling
that.
the
We
guide
really
back a
need
little bit.
detailed slice-by-slice CT data to see if and when
Yes.
and how you actually pull in the base, of the heart
Yeah.
by grasping more versus less tissue. Because that could be an
Right.
ancillary benefit. So for our operators, we have a question from the audience. What are the panelists' thoughts on using the AP knob versus torquing
Okay,
the guide sheet
we're steering
to
down.
go more anterior versus posterior?
So now we are going to go posterior, yeah, and then keep going.
And you're doing this with the
Medial.
knob as opposed to the sheath, Anu, right?
Yes,
Yeah,
yes.
yeah. This is
Right.
AMNOP posterior guide talk, pretty much
Right.
textbook.
So I think that
steering.
people are mostly using the AP
And now I
knob
want
and
to
not
straddle it a
manipulating the
little bit
sheath
more.
once you get the sheath in
No,
position.
there's no. Yeah,
AP knob,
Right.
M knob.
yeah. Okay, very good. Okay, BICOM looking good here. Okay, with a little bit of aorta hugger. We can
Okay.
go to
Little plus
posterior guide
five.
torque.
I'm
Yeah.
going to put a little plus
Yeah,
here.
that's exactly what we're
Give
going
plus
to
to
do.
the guide.
Yeah, because you have a lot of height.
Yeah,
so
that's
you should-
right.
okay.
Yep.
Exactly. So that we try to optimize all the trajectory and manipulation in the LA. So
Right.
that's pretty good there.
More light to see.
So
Do we need more plus?
Are you a little
let's see. I
posterior?
think we
I
have-
think so.
Little too
Yeah, I
posterior?
am
Two,
going
yes.
posterior
Yeah.
more.
Yeah, maybe we need to do more plus. You're right.
Yep. Yeah.
Okay, that makes us more medial. So we just
Right,
have
that's
to,
the other way.
You're too medial.
yeah. So just advance the stabilizer to make it more central for us.
Okay.
Okay.
Anterior.
So this looks better now, I think. Yeah, look at this. This is, I think,
That's
We have a
looking,
lot of
that's
plus,
looking a little
almost
better.
like 4 o'clock.
so we're going to raise the grippers now. We're going to unlock the clip, open the clip, and we're going to check our arm and gripper orientation.
Because you want to start a
Okay.
little medial.
Yeah, we're going to determine that
Your
in a moment. But
trajectory
I think
is
for now,
diving a little bit medial. That's my
Well,
concern.
Right, right. You're going to
yeah,
go more medial
yeah,
as you go
yeah,
in.
We'll figure that out in a moment, but we just want to quickly check the clip gripper orientation. So we're going to
Yeah.
drop the tactile down. Okay, what is it? Can you show us? I think it's posterior. Can you show us posterior, please?
Yeah, that's
There you
posterior,
go.
yeah.
Posterior.
Everyone
Posterior,
agree?
posterior.
Yeah.
Okay.
Tactile is posterior.
Non-tactile is
Yes,
anterior.
Yep.
Everyone agree?
Yes,
Very good.
yes.
Yep.
Okay, so we relatch and then so let's do 3D now to check our orientation as you guys mentioned.
Please, yeah.
Let me just jiggle more.
Yeah.
Because,
Wait, let me
Yeah, the
show.
3D would be interesting.
okay, let's,
There we go.
Take the true view off.
and anesthesia, if you can help us, Benji, slow down the heart rate, will be really helpful to our grasping. Okay, maybe some, so looks like we need to clock a little
Clock,
bit
Yeah.
and a
Clock
little
on
bit
the
more
top.
central maybe.
You have to clack a little bit.
Yep,
You are still
very
in the
good.
middle.
Looks
You are
very
in the
good
middle.
there.
Yeah.
Well, you're very central there.
And now fix the, yeah. Watch the anesthesia, watch your feet. So we take the parallax out, the clip arms at the same time. And you remember, there's a paper by Gagan Singh and Jason Rogers group on CCI that basically use that as well to make sure the clip doesn't rotate as we go into the ventricle. So
Right.
Stam, you think we are right or come little medial?
You are in the middle now. Let's put some color. You see the color?
yeah,
I'm going to bring it
So
medial,
the color-
okay?
The color is
You're in the
lateral.
middle now. It
Right
may
there.
move a
Lateral
little
clip.
medial as you go in.
yeah, yeah. We'll watch that. That's the whole idea of you doing the
Right.
floral. We go. Okay. Okay, I think we are ready to
Now we
go into
came
LV.
along.
Okay, two more down, Heparin, please.
Yeah, it's so you are medial now. You see?
Yeah, now a bit.
Yeah,
Should we go
medial.
little center?
Yeah, yeah. Yeah.
Yeah,
Okay.
That's better. That's
Okay.
better.
Yes, please.
That's better.
Okay, good.
Okay.
Clockwise.
Okay,
What
move to
ACT level we are
counterclockwise a little
targeting?
bit.
Yeah. It
About
does-
290.
About
Now it does
300,
look a
close to
little
300.
overclocked.
Yeah. Okay, what do you think about trajectory?
Yeah. Yeah.
I think it looks
nice.
pretty good, huh? Yeah.
Okay,
Okay,
we'll
okay, we'll close the clip and then we'll go in.
close and
So,
we'll go into the LV now.
Okay. All right, we didn't spin, which is excellent. That's good. We're under the valve. So I'm going to
Good.
open the clip now. Okay, can we check 3D one more time,
Yeah,
please?
Yeah, we do that.
Yeah.
We do that immediately.
It didn't move very
We are
medial.
overstraddled.
It
You're
looked
okay?
like it went in pretty straight.
Down the
Flora.
the 3D down. The 3D down. Yeah. Yeah. So you are a little
good.
bit medial.
Yeah, it's a little. It's
But
definitely
I think
medial.
that's the right spot.
And it's it doesn't look too
Okay,
clockwise
with
there.
here. Here we advance just a hair. So we turned down our tidal volume already. So now we're just fighting the heart rate.
Okay, I'm coming back.
Okay, we
Ready
got
to
to
grasp,
Yeah.
posterior.
a little bit more posterior. You want to- Okay.
Posterior is on.
It's buckling, so
Buckling?
yeah.
Okay. Should I go more posterior to get it?
Posterior is on.
Yeah.
Can't hear you, Saibal. Hold it.
You need to go more counterclockwise to get the anterior. Posterior is well inside. So go down and do counterclockwise. Go a
Yeah, the
little-
posterior leaflet looks perfect.
Yeah. So go a little bit more down and then catch the anterior. Advance the clip.
There
I'm
you
okay,
go.
I'm going back in.
Yeah. Close it to
Yeah,
120.
can you close it? Closed.
And then
Yeah, we'll
counterclockwise.
close a little
You're-
bit.
you're-
Anterior
You're getting a
grip.
lot of posterior. You need to
No.
get more anterior. So you need to go counterclockwise in your guide.
Yeah.
That's better.
No, anterior is not
Yeah.
on.
I think we're buffed. I think we're a bit
You
buffed.
need to go down.
Yeah.
Yeah, there you go.
Yeah.
There you go.
Now
No.
try this.
Yes, let's make sure that
Going
the
down.
clip
Comment is
not
check your
rotating.
orientation again.
Yeah. Let's do a 3D to make
We
sure.
can do a
are-
3D.
Okay, okay.
Floral looks good, so
Howie, why don't you come up here
Let's do
too?
3D.
You've done
Malcolm, let's do
thousands of
3D just to make
microclips
sure here.
We're going to bring Howie Herman to the panel
Yeah.
as well.
6 is okay.
why is the heart rate so fast?
That's right.
He feels-
I like
I would
But-
counterclockwise the clip a tiny bit, right?
Okay.
Orientation is good, so we just come up. And He's selling counterclock, listening clock.
Okay,
No,
anterior
anterior
is
is on.
on. It's posterior now.
Okay, now you got the anterior.
No, no, it's not. It's not on.
You may have to get it separate, right?
We can.
Oh, your posterior is caught,
Yeah.
it's
buckling.
buckled.
Curl.
Yeah. So go down a little bit, free the
Yeah,
posterior.
you got to
leaflet.
free up the posterior
Yeah, you
leaflet.
got to free the posterior leaflet. Yeah, now it's okay. Let's keep buckling. You know, I wonder whether it's the cords, the
separate?
cords which are.
Okay.
I think it will make, we can try that. Okay.
When you miss anterior like that and you consistently get posterior, I worry that your orientation isn't as good as you think it is.
Yeah, we just checked it, Howie, on fluoro and on echo. So they said it was okay. It was like on 12.6, but we can counterclock a little bit, as you said.
Yeah.
You guys suggested to see if it helps. Yeah, there you go. You can
Anterior
see
is
the
on.
arms a little bit more now.
Anterior is on.
Now go posterior.
Close anterior.
No, we lost anterior.
Posterior is on nicely.
Why don't we do separate?
Should we just get posterior first?
Grasp. Yes.
So
Yeah, that's-
tactile is posterior, right?
Yes.
Howie, you're shaking
Okay,
your head
tactile's
no.
posterior.
Why
We
would
gotta
you
drop.
not do independent grasping?
I mean, I worry in this situation that you're a little bit off angle, even though you think you're not.
So
I
you're
would
worried
look
about twisting.
I would look really carefully. I think independent grasping or the Tarzan maneuver is a last resort, that
Yeah.
you always want to try to get
Yeah.
both leaflets together so you don't twist it. So
Right, right.
I,
Or tear.
Too
Let's check
medial.
one more
Did you
time,
see?
3D.
He may be
Check,
interfering with
Okay.
the cord.
We'll check 3D.
If you go
Yeah,
in the
maybe we'll
middle
check
of the
3D one more
valve,
time.
Why don't you look at the 3D again?
You put it in.
Yeah,
Bring the
that's
alpha,
the
yeah.
orientation's off.
Increase the
and-
gain.
you need,
Or the clock.
And it needs to
it
be
needs
more
a little bit of
clockwise.
clocking.
Clock,
You're still,
right.
you're off a little bit.
Clock
I think
limit,
you need
yeah.
to clock another
That's why
half
the
hour to
3D
an hour.
helps a
Yeah.
lot.
Clock, yeah.
Yeah, I think I would
Okay.
push it
Clock?
in a little.
I would
Yeah,
be
we did.
more central.
We did.
I think we're caught on the posterior. Just one moment. Yeah, see? There you go. We can go a little bit more central. That's fine.
You have
Less
anterior now.
cords
Yeah.
in the middle of the valve. And since you're using a wider clip, you're getting caught with
Yeah.
this.
Go ahead. Yeah. Okay.
Yeah, that's where the wide clip doesn't
Yeah.
help, actually. Especially if you
Anterior.
think you're going to need two.
Yeah, I'm more of a fan of NTW and these tented valves because I think you put a lot of stress on the valve when you grasp it.
A little anterior.
One thing you can do is not close it all the
Anterior?
way after you get
Anterior. We're
both
going a little
leaflets.
anterior now. Don't pull up yet. Looking better.
See how the anterior arm is still a little bit foreshortened relative
Yeah.
to the posterior arm?
Yep.
That makes me think you're still
Yeah.
off a little bit off the prolapsed area of the anterior.
Well, we could do one more time on 3D, but you saw the 3D was pretty good. And
I,
floral,
I
like
thought
I
it could
said,
be
that's not
clocked a
change.
tiny bit more.
Yeah.
Need more clock?
We all thought, Gilbert, it could be a little more clockwise.
Okay.
We're clocking.
We'll clock a little bit.
3D.
Yeah. Yeah, we did now. We did. We just did clock, more clock.
Maybe
No,
a
now it's
tiny
too
bit
mu-
of
now it's
plus.
too
Like
much.
12:30.
Yeah.
But you see how
Yeah,
they're,
that's too
Yeah, that's
much.
what I'm saying.
I
Now
think you
come
need,
back 1 degree.
and then I would go just a tiny bit more
Yeah.
lateral where
That's
that
better.
prolapsing.
That's better.
Yeah. Yeah. That looks
Okay.
better there.
Now we are more
That-
lateral
that's
than the
definitely-
medial.
That's more
It's very-
lateral
it's
now.
quite lateral.
Yeah.
It's
That is
definitely
quite
quite
lateral.
lateral.
That's the most lateral you've been. Well, sometimes you have to start lateral.
We can if you want to. I mean, sure. Okay. Let's just.
We get anterior and then go.
Anterior is on.
Entry is on.
Yeah.
The heart rate is really trouble.
Yeah, the AFib and
I-
what is about 90? or 85?
Yeah, we usually try to go at 60s, 70s, but the medication doesn't seem to help. So
We got digoxin and other things also. or
Give
no?
him a little,
Dej,
little
nobody believes in
Esmolol.
Dej.
Put on some Esmolol,
It's
slow him
good.
down a
we
little bit.
tried. They tried already. They
Esmolol
did.
We tried, right? Yeah. What about Dej? No.
You could also
So don't
open the
use
clip
Dej, huh?
just a little bit more. Go to like,
Yeah, we could. Yeah, we do that. Okay, go to posterior now.
What do you think about adding a tiny bit of plus?
2 more
We
thousand
had,
happened.
We have
had
a
a lot
lot
of
of
plus.
plus already. We can go
Tell them
even
2,000
more.
happened.
Okay, we did.
Yep. Okay.
Okay.
No, lost anterior. It's stuck. I think.
Yeah, because
Yeah.
of the
And now I
plus.
think you're really,
Yeah,
really out of plane with that plus.
Totally disoriented.
yeah. So let's try to do 3D again just to make sure we are. We also overstraddle a little bit too. So yeah. Okay, not that bad. Okay.
with a green
You guys
counter.
happy with the orientation?
A little bit of counter.
Okay. Counterclock?
So going just in the middle of the jet, where you get the most leaflet, least cord.
Do you want to go lateral first and then
We can do
come
that
back?
at this
Raj's
point.
point
Because,
is
no?
very biased.
Well, look,
Put a clip in.
it looks like with this, again, with
That's why I'm
the
thinking.
length of these graspers, you may need to go central.
Yeah, we're going more quite essential now on the BICOM, right? So just the
Push and
heart
hold.
rate is very
Saibal,
hard
Saibal,
to.
push and hold the,
You're very biased from anterior to posterior. Your trajectory is not perpendicular
Yeah.
in the
Then why don't you
LVOT
go
view,
lateral, grasp it,
and
then
that's
come to
trying,
the
we're
center?
trying.
hurting you,
We're trying.
right?
Yeah, that's why I'm saying maybe a
What'd
little
you
bit
say?
of plus.
But the thing
No,
is
we
that
have
you-
actually we have more than 180-degree plus Saibal and Raj.
Yeah, I know
Very
that.
plus.
I know that, and the reason for that is because your puncture is not posterior. If you had a posterior puncture, or a low transeptal puncture, more
Right.
you wouldn't be so biased. Right?
push and hold, Saibal.
Yeah, if your puncture site was a slightly lower or a little bit more posterior, you would have not had this much of bias. That's making it challenging.
Up the posterior. Ready? Close the clip a little bit.
Especially with the
Close,
long
close
device.
Close. Close more. Good. Drop posterior. Okay. We're going to drop the posterior, the tactile. Good.
So how often do you ever
Okay.
do a
Posterior is
second
down, right?
puncture when you have puncture regret? I've never seen it. You somehow just work through it, but
Yep.
I'm sorry?
Don't
Not
have
much.
much of posterior.
Not much of the posterior.
yeah, I know.
Not much.
Unless you're really far away.
Okay.
Doing independent grasping, right? Which is okay.
Yeah. Okay, raise the posterior.
Looking a little
We'll
better.
get more posterior. No, we'll get the posterior. There was a concern about how much posterior there was.
The way the posterior
Let's just
is
check
buckling,
orientation
do you
one
think
more
you-
time.
Do you think you grabbed a cord on the
Yeah,
way
let's
up?
just check orientation. I don't think so. It has been curling. So
No, we are
Yeah.
now in the center. Let's go
the
lateral.
center, yeah. Okay. All right, that looks pretty good, guys. Right? Everyone agree?
Yes.
Yes. That heart rate is very hard to work with.
Yeah. Posterior nicely.
Okay, drop the
Okay.
posterior.
Okay, 1 second. It's very dynamic, right? So
Did you want to give a Esmolol drip he was talking?
can we try a smaller drip?
Esmolol drip you have?
We
Okay,
really
ready,
need to
ready.
bring the heart rate down.
It's not curling anymore. Looks like it's laying flat on the arms.
What are you guys saying of the posterior now?
I think esmolol. Esmolol should work. Everybody feels esmolol.
Okay.
Yeah, go up on the esmolol. I'm sure you can slow
You
the heart
got
rate.
you got a very good posterior.
Okay, we got
insertion.
posterior.
Yeah, so counterclockwise is
Okay,
pretty
good.
Yeah,
anterior.
you got the posterior now.
Close the clip a little bit.
Close it
Yep,
to 120,
close the
otherwise
clip a
the
little bit.
anterior will fall off.
Yep. Correct.
In posterior.
Yeah. Don't close too much. No, close too much. Hmm.
Still look like you're just somewhat out of plane for the anterior.
Let's go more lateral.
Do one
We are
3D
lateral.
view just
No,
once.
more.
Just,
Yeah, could
Yeah,
you
Yeah,
show
sure.
us a 3D
Just
real
the
quick?
3D, Malcolm.
We're lateral.
independent,
yes.
you get
Yeah.
A little bit more.
Well, it's not bad. I mean, it may be,
Yeah.
no.
A little counter.
Oh, yeah.
You might be able to go counterclockwise a little bit.
Yep.
You're coming up. We are way anterior now with the guide.
Clip a little bit further, see if we can get underneath that anterior.
Yep.
Okay.
that's gone, making it so difficult for you is the trajectory. It's so anterior to posterior. So one of
So
Yeah.
several questions. So can you check that after your septal puncture itself with whatever sheet you have and then change it at that point?
yes, you can, of course. Once you're inside, you can actually check your trajectory.
No, you can see where it's tenting. I mean,
Yeah, but I mean, now at this point, but now at this point, it becomes challenging. I'm just thinking what correction. Clockwise on the guide and then giving A&R, but then
I don't think we're under the free edge of the anterior.
Yeah. You want us to open more?
No, we can go in the
Go
more
down a
ventricle
little bit. Yeah, and then try to get the, yeah, now. Now go anterior.
Try to close the clip arm a little bit, create a V for the anterior to fall into.
clip a little, otherwise
see
the
that
anterior
arm,
will
though.
slip off.
On the anterior.
yeah, you can see the
Going
shaft
more
of the
laterally a
catheter.
little
It's
bit?
going so
We're
much
lateral
anterior
already.
to
We're
posterior.
lateral already.
Yeah.
Right.
Close the clip a bit.
It's better to start over again. Like, it's okay.
Yeah, that's
Take
say
the
that.
posterior leaflet off, go center the valve, go and come, bring it back to the atrium and see if we can get a better
Yeah.
trajectory.
Try more plus.
No, we had a lot of plus. We do right now. Okay, now it's better, I think. Everything is, they're falling in place, yeah.
Ready,
Coming back.
ready.
Ready.
Another point is, will anybody think about changing to the NTW?
Nothing to do with the.
Keep the same transeptal?
slit.
Yeah.
It's the transeptal, yeah.
You know what, let's get to anterior first.
So we
can
need a
optimize
more
posterior.
directional sheath.
Of posterior. Okay. Let's drop anterior.
That's why
Okay, we're gonna drop
always saying
anterior.
that it's
Yeah.
easier to get a
Show us.
trajectory if you're posterior in your puncture
Anterior.
site, right?
Yeah.
But you can be low by compensating, it,
Dropped anterior.
Is down,
right?
it's
The
bouncing.
more anterior
Yeah.
you are on your short axis view and transeptal,
Now we are
have
getting
this
it posterior.
Partisan?
I think this may be an opportunity
Still very far,
to
they can't get.
Yeah, to lower the anterior gripper and then go posterior.
Slightly posterior and advance.
Yeah, the anterior
We
gripper
have
is
actually
down.
lowered the
Yeah.
anterior gripper. Now we are
Okay, this is great,
going
yeah.
posterior. Yeah, yeah, yeah.
Yeah, exactly.
Mm-hmm.
Opening the clip arm.
That's looking a little better.
And now we are going to
Okay.
go.
You're gonna scoop posterior.
Come posterior.
Yeah, pull
Problem
up
is
a
the
little.
heart rate, if the heart rate is, if the heart rate is slower, this would be less challenging.
Push the esmolol. Every 1 to
No,
2
the bed
minutes.
is clear.
Increase the dose.
Okay, go.
It's buckling, so
He wants to cardiovert.
now,
No,
It's
that
still
will be tough
curling.
now.
okay, ready?
Alright.
You have the posterior.
It's buckling, right? You saw that.
No, no, now it's not.
But come posterior.
Close the clip a little bit more.
Yeah. Close.
Yeah.
Try again.
Do me a favor, do a 3D here.
No, it's okay.
You can see a shoulder on the leaflet.
3D, please.
Yeah. That's it. Yeah. That's it, brother.
It's good.
Okay, pretty good. Okay, 2D.
Yep.
Every time 3D is saying the orientation is good. Okay, go more posterior. Yeah,
Oh, no, too much.
Getting better.
That's probably the
yeah,
best.
keep pulling up.
Open.
Yeah, why don't you take that?
Yeah.
We're saying take it. Does everybody
Take it,
agree?
take it.
Open.
Take it.
Yeah.
Okay.
Okay, the whole panel
Yeah, drop the
agrees.
grippers.
Grippers.
This
This
is
is great.
Yeah, we dropped the
probably
grippers.
the best
Okay,
you're
good.
gonna get. And you can
Okay,
see
good.
you're no longer, the
Close.
shaft's no longer PA.
Oriented.
Yeah, close slow,
We are closing the clip.
Look at the posterior,
Push and
please.
hold, Saibo, we can't hear
Thank
you.
you.
Usually, we always check orientation to close the clip. I usually
Close.
check orientation before grasping and after
measure-
grasping. Because
measure posterior.
if you distort a valve with an
Okay,
XT,
why is it
that's-
frozen?
We're closing.
Sam, we're closing. Can you go live, please? Okay, we're going to close to 60 now, right? Okay, lock, please.
That's the most central
Okay, check
orientation
insert-
you've had.
Check insertion before we close. Check insertion.
We need to optimize posterior.
What was the leaflet length again on this side? It was like 1
1.8.
point.
See a
Posterior.
frozen
one.
Okay,
image
so we
here.
have,
I think we got,
no, we are measuring the leaflet length right now,
Okay.
residual leaflet length. Okay, all right, okay, go live. Can we show color and we close?
Yeah.
Okay, we're gonna close now. We're gonna
looks-
do a little
that
more
looks pretty
posterior guide
good.
torque. Color, please.
are you happy with the insertion now? Stan?
Yes.
We'll see. Okay,
Closing to
closing.
0.
Can you put the cursor on the clip, please?
Yes, sir.
You still may have moderate MR, but I think
Yeah, we'll put a
that's-
second clip. That was
Yeah.
our plan all along, so.
Yeah, but I think this is as good
We
as you're
close it
gonna
up.
get with that.
Close
Okay.
it. Close it up.
Close
Close.
to 0.
Good. Okay. All right. We're gonna close.
Yes.
Okay. That's
And give
it.
us a gradient. Next one will be lateral,
Medium.
medial to this.
So we went lateral.
Yeah, let's measure the gradient there. Let's measure the- Yeah.
Look, ultimately, I think that's pretty good position for the first clip.
Offline.
I'm not very impressed by the
Yeah.
MR change.
Yeah, we'll put a second clip for sure, but let's look at the color and
I'm getting
stuff
a mean
first
gradient
and
of
see.
5. So let's look at the.
Yeah, but a
let's
lot
look
is still MR, so the valve is huge. What's the valve area?
8.
Yeah, 8.
So then you may not have changed much. Can I see the MR color?
Yes. Can you put the color there?
Oh, lateral.
So to me, the jet looks more lateral.
Yeah, interesting, right?
Lateral. Yeah.
Yeah,
But you'll put a
lateral.
second clip anyway. That's
Yeah.
okay.
Yeah, but you
Yeah.
need
But-
a
but
second.
Well, we
should
have a
be
lot
lateral.
of
It's still
we have a
moderate.
lot of stored tension here, so
Yeah.
yeah, we'll
Right.
we'll have the second
So
clip
that
for
might
sure.
relax a little bit.
Yeah,
But actually,
you happy with the
you
insertion?
mentioned the gradient. Is your gradient about 5 now?
everything's close.
5, yeah.
You know, this
Are you happy
MR
with the
was so
insertion of the
severe,
posterior leaflet?
I wouldn't go crazy worrying about the gradient. I think the benefit from the MR reduction
Exactly.
is going to be much more than the
So it's
gradient
11.
of even 7 or 8.
11.
You know, I don't want more than 10, but
So you're happy, and you're happy the leaflet is not buckled inside, right? Yes?
Yes.
Not working.
I think that looks all right.
Go lateral to the clip,
Lateral, please.
lateral. Let's see how the leaflet looks. So we sometimes look at the leaflet lateral to it just to as a kind of an eyeball to see how much is really in.
Yeah,
Okay,
it
go
doesn't-
medial.
It doesn't look like it's buckled.
Yeah. Also, the
Go
gradient
medial,
may be high
go
because
medial.
the heart rate is high, so,
Right.
you know,
Exactly.
That's
and there's a
right.
lot of MRs, so for
I think
sure
it's
I would
reasonable.
go for the next clip.
I think we have enough, right?
Yes.
Everyone agree? Okay,
Yes.
then
I'm
let's-
worried
let's
about
deploy
how
this
much
then,
posterior leaflet you have in the clip that you don't have the 9 or 10
Yeah.
millimeters you'd like.
Howie, you're worried, right? You worry about the leaflet length on the posterior?
As you know, with the XT device, you have to be at least
You need 9.
8 or 9 millimeters in,
Yeah.
or you don't. All of
9
the
now.
grasping action is at the base of the clip, not or at the tip of the
Correct. We
clip.
got
not at
what
the
do we have
base.
for leaflet length insertion?
11.
11.
So the actual imagers, Stan and Malcolm said we have 11 in roughly on the calculation.
Good.
Still looks very mobile to me above it.
I mean, we can optimize if you want to just to check, but it's not going to be easy, as you know. So it doesn't look close.
Can
Well,
we
we're
see-
very close. So
Can we see 3D?
You're
with
right.
Can we see 3D with color?
30.
yeah, it doesn't. You're absolutely right, but we already closed all the way in. So either something is not. Yeah, you're right. Maybe you want me. Well, we can undo the fastener again and unlock and make sure. Yeah, you're right. No, that's a good point. The clip doesn't look closed, even we already closed perfectly. So what do you say? So just
Give in, he's saying.
give back,
Medial. Lateral, lateral.
close.
The color change
the
is
max.
not
No,
enough.
this is-
There's something wrong going on there, you're saying, so.
Huh?
I agree. It looks distorted to me still. It's angled a little bit. It's
Yeah.
and the
No, I
MR
agree with you.
reduction
I
has
think the
not
clip
been
is not
very
fully
much.
closed.
For this big a clip, you
Okay,
should have
so
some
we-
MR reduction.
Yeah, so I think what we're going to do, we need to troubleshoot because the clip is not closed fully. You can see that here on Floral, right, everyone?
Yeah.
So I think we need to troubleshoot.
You
I'm
keep
sorry?
very much.
A core in the clip. Well, I mean, we can optimize the posterior and see. Why don't we do that? Okay, so tactile, right?
Take
Okay.
the, optimize the posterior, right?
Yeah, we'll
Posterior is off.
Oh, if we lost the posterior already, so we can see that.
Howie, you've been saying from the beginning that you think that they
I
might
think
be-
they grabbed a
grabbed the cord.
cord on the posterior, and that's why the posterior leaflet's buckling and not going in all the way. And the fact that you lost
Yeah.
it tells me that you didn't have good grasp
Right.
on the posterior
Go
leaflet.
back to Ariel.
So would you just
Yeah.
release, pull out, and start over?
I would try to improve the trajectory by coming back into the left atrium and starting over with your trajectory assessment.
Well, let's get a BICOM explain to reassess the situation first. Yeah, I think our orientation has changed.
Our orientation has not changed, out there.
Yeah, I mean,
It's the same.
Aorta is at the top.
I'm saying?
Has a,
And we can go back into the atrium and reset, but we can do that too if we want to.
Yeah.
yes.
I think that's kind of the feeling to do that. Make sure
Okay.
everything's
Okay.
working.
Let me see.
Try
Okay,
to come in with an
all right.
Take it
optimal
goes out.
orientation.
Okay,
Inward.
okay, 2D, quick. No, invert.
Invert.
Yep.
Okay,
Then you
we'll
can
come back to the,
increase the azimuth.
Yeah,
while
we're
you're
stuck
doing
in
this.
I think you're wrapped
stuck
around
in
the
the
cord.
position.
You
Invert,
need
invert,
to
invert.
evert the clip.
Invert.
Yep.
Yeah, wait, that's what we're doing right now.
Yep,
Now you're
we saw
free.
that.
Now you can come
Okay,
out.
yep,
Come out.
yep. Yeah, I know.
Full.
Okay, that's fine. We'll do it. Okay, well, let's take a look again.
Get it 2D.
So what are the tricks to avoid catching one of the cords? Or do you just need to have a high
Icom,
level
explain,
of
please.
suspicion it can always happen?
So one of the rules are near the commissures of the valve,
Can you find us?
then don't use white clips
Yeah,
because then you have a high chance of concordant cords.
but I don't think they
When
thought
you,
they
if
were
you're in
going
the
to be
middle
near
of the
the
valve,
commissures. That's-
you're okay because you.
I don't have room.
But I think they anticipated
Yeah.
being near the middle of the valve in this case.
Don't put too much plus. I think plus is
No,
against us.
but when you have a septal hugger, you're a hugger.
You go to 0. You go to yeah, no.
Please.
Okay.
How's this trajectory looks a little bit more favorable now, right? Do you
Yeah,
guys
that's what we're
agree?
thinking.
or-
It looks a little bit better.
Yep.
But we
Not as
are
posterior as you were before. Yeah, clock it a little.
we bring it more central.
You're in the same position.
There you go, that's plenty.
And when
plenty.
you advance it, look at the trajectory when you advance it. Because it still
that's
looks like it isn't going
How's this?
straight.
This is yeah. Yeah, but we have a lot of plus, remember, right? So we have to counter that with less M. So
I think it's more promising.
Okay.
More promising now.
all right, we'll close the clip and go in and try again.
Yeah, that looks better.
Better, yeah.
But the question is, can you keep it in that orientation?
Yeah, we can. We have yeah.
You want to?
Okay, we're already in.
straddle?
Okay.
Take a little bit of
All right,
M
that's
off. You're
fine.
diving medial.
Yeah.
Yeah.
okay.
Well, very little M actually. Our M is 12 o'clock. Yeah, it's all because of the plus. So okay, all right, let's try again. Come
I'm
straight up.
surprised we cannot decrease the pulse rate further.
Straight up.
With everything else, we cannot bring it down, huh?
No, too much.
No, but what about diltiazem? We don't give dilt?
This
We
looks
can
much
get it
better.
from there.
Your
Get the
clip arms
diltiazem
are
from there?
more equal length. Both
Everything
leaflets
looks
are
good.
hitting
It just needs to do it.
the device.
Now, what else can we do? Because we need to bring it to 80. That's having a trouble.
Problem is the rate, the heart rate. Otherwise, in normal circumstances, you would be able to.
No, but diltiazem, let's give dilt, no?
So
Esmolol you had?
I don't think cardiovascular.
what dose of Esmolol are you on?
Brings it down temporarily to like 100. Posterior looks like it's coming in.
You want to
The
cardio?
posterior is good, but anterior is not on. It's very hard to get
Give
anterior on.
0.25 of
Dilt from other
Dig-IV.
room.
Start a cardism drip. You can slow this
Yeah,
down.
Dig also they're saying.
Yeah, give 0.25
Everybody's
of
saying give little
Dig-IV.
dig.
Go down.
0.25 of dig will help.
Open up the clip a little.
Yeah, we're
bit.
down here, Sabo.
Okay, good. They'll be there. Open up the clip a little bit.
No.
Negative?
No.
He's saying try it.
No,
Okay, we are
no.
going negative.
No. Okay.
Looks promising.
Yeah,
Okay, we are coming up.
Leaflets look symmetric. They're both hitting.
It's very symmetric.
Device.
It's a symmetric V. The problem is that when the heart rate is high, and diastole, your arms are, even this is XT, this is not even NT, the leaflet is going to, get kicked off, right? So, I think we should try to do anterior again and then go posterior. I just don't see with this heart rate how we can do both at the same time, even though they're on, it's not going to be on sufficiently. Even now, it's challenging.
Go down.
Yeah.
Yeah.
Once again,
Go down. Yeah, we'll go down.
Yeah, okay.
Go down with the
Going down
glucose.
an anterior
Yeah.
clipper.
Non-tactile?
Yeah.
Down.
No.
Do we have enough?
Not much.
Not enough?
Not enough. Not enough. But we can get this and try to go posterior. Left.
Or you need just enough diastolic time to let it rest so you can actually drop it, you know.
Posterior.
It actually looks like the heart rate's a little bit slower, Gilbert. What is it?
Yeah.
Is it around
Still
70
about
now?
100.
75?
No, not even
Still
close.
about 100.
Maybe 95.
Oh, okay.
It's 100.
100.
Okay.
Okay, try now.
You're on a fast
Anterior,
sweep then.
anterior is going.
Anterior buckling?
Well, I think acute cardioversion is not going to work, right? You can't cardioverter because it's such a big atrium.
Okay, ready?
That's better. That's better.
Samin, did you give any
Anterior's laying down.
digitalis?
Yeah, that's what we are getting now.
Cool.
Get 0.25 a dig. You could start a cardizem drip.
Yeah.
I don't know if is the
Anterior grip
Esmolol
is
at,
Yeah.
what is the Esmolol drip at?
Now, they're giving the cardizem drip now. Yeah.
Have the
that's the
anterior
cardizem.
leaflet, okay?
No, he's asking, do we have Esmolol drip going?
Is Esmolol going?
Take it off, take it off.
You have anterior leaflet.
Lift it.
No,
So
they-
why don't you try to go
Not
a little
enough,
bit
not
down
enough.
clockwise and get. try
Yeah,
to-
yeah. No, I know, we tried. We'll try again. Okay.
Everybody
Try
feels that
anterior
maybe
again.
digoxin will help
Anterior
also.
pursuing.
0.25.
Okay, now we're
goes
talking.
down.
Okay, good.
I mean, I think digoxin will work better right away. Yeah, 0.25 dis, please.
Yeah,
Okay, we are
Esmolol
giving
works
dig
great
and then
in
dig.
in this setting.
Clockwise your
It
guide?
probably works better than anything. And it,
Yeah, we are. But you see the buckling, right? So that's what Howie was talking about earlier.
yeah.
I think it looks better. It looks like it turned a little bit as you pulled up, but I would take anterior here and then
I know,
just
I
try
know.
to clockwise your guide a little bit. I think you have
Yeah, the
both.
anterior looks really
I
good.
would take anterior, I would clock a little bit and take posterior.
Anterior is good.
Yeah, take it.
Close the clip, close a little bit.
And then you have, yeah.
Take anterior.
Are the
Close a little bit
grippers-
more.
Anterior grip is down.
Yeah, no, yeah, I know.
Posterior.
Yeah.
Oh,
Okay,
beautiful.
go.
Okay, go. Posterior now, down.
Oh, great.
Posterior is down.
You see bouncing or no?
Yeah.
I don't see bouncing on the group.
On the
Yeah,
posterior, no.
raise the posterior. You're shadowed by the posterior. That's why you don't see the bounce. You don't see
Posterior
it.
coming back up.
No.
So question from
Probably
the
a bit more
audience on
posterior.
which scallops are being grasped by this clip? So this is just standard P2A2. You know, it was
Can you show us
mainly a
posterior
central jet.
better, please? You only show us anterior.
Open a little bit.
We're all the way to the annulus.
Yeah.
Yeah.
You lost it.
No, I know, because you're shadowing, and I need to see the posterior. We need to see the posterior to make sure because I'm keeping posterior guide top, and it's not going anywhere. So either we're going against the annulus, or we're not seeing enough of the posterior. Ready?
I think you have it there. Why don't you drop the gripper
We're gonna
there?
go in now.
I don't know we have enough. That's the thing. That was your point earlier, right, Howie?
Yeah, but
So,
this looks
okay,
better to
fine.
me.
Okay,
Going
good, go,
down.
go. Okay.
Close
We
it
don't
and
see gripper bounce. That's the only concern.
Measure it
Okay,
and
go.
let's see the color.
Well, just
Closing
close
to
the clip a
16.
little bit and advance it so you take the tension off.
Right.
Yeah, no, see, we didn't have it. We don't have it.
Yeah, no.
We don't have it, see?
Let me get the
Position's
correction.
already out.
Was it
Tactile. It's latched.
tower?
Yeah, no, it's under.
You go more to the. Yeah.
It's cold, so.
Okay, we're going to go back in just to show how long the posterior leaflet really is. Look at that.
Yeah.
Okay, so we're going to scoop now. We're going to scoop now posteriorly.
It keeps going.
How's that?
I think we may need to give
More
DILT also.
posterior.
DILT make little difference, but not much.
That looks a little bit more promising.
Yes.
Yeah, it's,
Okay.
All right.
Okay. Right, drop. Just drop.
Dropping one more time.
Drop. Okay, now we see him bouncing.
Yeah.
Okay.
All right.
Okay, close
Close.
slowly, close slowly.
No, you don't have it.
Very dynamic. Okay, close. 60. Lock, lock,
No,
lock.
no,
Oh, we lost again.
no, you don't have it.
We lost it again.
Let's see. Yeah.
You need to lay the clip down.
It's latched.
Now you can actually, have you seen how the bias is in the opposite direction? Now you can take a little bit of positive off your guide. It'll help you to
Now
get the
you're really going
You really,
posterior to anterior.
Yes, exactly. So open your clip.
you think
and
we
then
should
make-
do, we should change,
to,
if we change less, less plus?
Yeah,
You
see
have to
now then
scoop
your
under the
orientation,
posterior
you help the
leaf.
posterior leaflet.
Negative will allow you to do that.
I see what you mean, but you're not worried about twisting the valve, right?
Well, it's
No.
either we
Okay.
need to do way
Okay,
more
ready?
plus or way less plus.
We're doing
I
less
think we
plus
have to
now.
go less plus.
We're doing less plus now. Okay, now they're in. Okay, drop.
Come off the anterior.
We dropped it.
Oh, okay.
Yeah.
That's bounce. Okay, that's good. Let's close there now.
Yeah.
Yeah, we're closing.
Stay in this view, please.
That looks like you got it.
We're close
Oh,
to
we-
60.
No, we're losing it as we close. It's
Still losing
interesting.
it?
Yeah.
Want to give back to no posterior?
Yeah.
No,
No, don't look.
we're not lose, we
you
lost it again,
We're losing it as we close. It's interesting, right? You saw that? Everyone saw that, right?
unless we tore it.
No.
Yeah.
Okay, show us, please. Okay, I think maybe we didn't go in ventricular enough, perhaps, that's why.
You might be fighting kind of like the belly of it.
Could be.
Here, that's now more ventricular.
Take note of your intercommissural trajectory. Coming from lateral to medial, you see that, right?
Yeah. You think we're not ventricular enough,
You
that's
wanna
what
see
you're
the
thinking,
Release the
right?
anterior leaflet. Don't give it. It's not helping.
And your intercommissural trajectory looks off.
Let's do 3D.
We can do one more time 3D.
Yeah, let's see the 3D one
3D
more time.
orientation always has been right.
Yeah, 3D looks perfect.
Every time 3D has been good.
Yes.
Okay, let's go back to 2D and try to do it again. I think we just maybe not ventricular enough. So we're not grabbing the leaflet. It's quite long, right? I think the leaflet was at 1.8.
8.
See, look how long that is.
Do we change it to regular clip rather than wide?
Why don't you release the anterior leaflet? It's not going to help you now.
Okay. But the heart rate is so fast,
He gave anything?
They got digoxin now. It still didn't work. Now they're waiting. I think we need to give DILT now.
I know, so,
That's okay.
Yeah, please.
The dig can take 10 or 15 minutes.
yeah.
Lateral, medial,
You gave 0.25.
Yeah, I know.
That
Yep,
can
yeah, we
take-
give that.
pull back.
Take 10 or
Yeah.
15 minutes to work.
We caught.
Esmolol works in a minute.
We take off M.
We had lot of M off because of the plus, right? So now we're caught.
You feel stuck?
Yeah, it looks like the shaft is stuck if you look at the, here.
Okay, now we came.
Now we're unstuck.
Very close.
Can you get us a better BICOM image, please? It's like all
So,
rotated.
Samin, we're about 18 minutes over. Do you want us
Yeah.
to go to a lecture and then
Yeah.
come back to you?
Lecture, right? Lecture.
Yeah.
Yeah,
Yeah, I think it's a reasonable now. So we said we give.
Let's
full
get the
1
heart
hour.
rate. Let's get the heart rate under control. Then we'll try again.
So I think it's a reasonable, Greg, you start the lectures.
Okay.
And we'll come back, once we are, I will give you the signal while we control the heart rate, more digoxin, more diltiazem. The question is before we go offline, anybody will think about changing it to NTW now?
No.
The clip or we just try on this?
Stick to
XT.
XT. It's okay.
I say. Okay? All right, so Greg,
Okay,
it's okay?
Greg.
All right, so we'll go to, we'll do
you
one
go-
lecture. And we have Eberhard's keynote lecture on
You can give two
future
lectures,
next
yeah.
generation. You want us to
Two
do two
lectures.
lectures? Okay. So that'll be
Yeah.
almost
Yes,
30
please.
minutes. And then we'll come back to you.
Dr. Kinney?
Are we live?
Yes, we hear you and we see
Can you see us?
Yes.
Okay, as the panel had mentioned, at the, when we said we are going to leave, we tried once more reorientation and everything, but did not help. So we did take out the whole system out and repunctured. As suggested, like you had mentioned and everybody else, that when we did the second, even the second transeptal was not easy. So first time we went with SL thinking, but then we had to go back with the Mullen sheath itself. We went inferior and posterior, more posterior. And I think you can
Malcolm will show up. Yep.
Malcolm, show the echo quickly.
Having a little trouble hearing you, Anu.
Gilbert, I thought I taught you MitraClip. I taught you one thing, and that is you do posterior puncture.
Okay, this
Yeah.
is, can you hear me now?
That's a little better. Thanks.
What you did is a low puncture and posterior, right? But it's
Oh, no,
bicable.
no. Yeah, the distance was about 5.5 the first time, so it was a big atrium, so it's not low, but I think it's just maybe more interior, as you said. So we went more posterior this time. You can see that here, and then you want to just go the
See,
next
there are
step
two
with
parts for teaching. You in the bicaval view,
Yeah.
you are low. Do you see that? In
Yeah.
bicaval, you're low, and in the short axis, you're posterior. And that
Yeah,
that
they're more
prevents you
inferior
from a
posterior.
wall hugger. Yes.
Yes. So you can see now, we put in one XTW. We still have to do independent grasping because the anterior, even with a quarter turn plus, it was still challenging to get there enough anterior leaflet. So we did anterior leaflet and scoop to get the posterior leaflet. So we deploy that, and we have a lateral residual jet. So now we're doing, we're just ready to deploy the XT here, lateral to the first clip.
So first one was XTW, the second one was XT. But I think once we got our transeptal right, it was just a matter of 10 minutes to do both the clips.
That's beautiful. This is a very good teaching lesson for. Is that the result? That looks really good.
Yeah, that's
Yeah,
great.
we
You
haven't
just got
deployed yet, but
Trace,
that's it.
Trace MR
Yeah.
et al.
Yeah,
and
it's Trace.
but it just shows you how important incredibly important that first transeptal puncture is. Spend a few extra minutes, get the position right, especially that posterior location. Makes all the difference.
And you shown the gradient, Malcolm?
I think Dr. Kinney accept we just
Oh,
So your pulmonary veins have
So we go,
normalized.
we are ready to release.
Yeah.
Yes.
So
So if everybody agrees, you are going to release the second
Yes,
clip
yes.
also.
Yeah.
Okay.
Can I just see a few color images, like, just for the audience to show some echo images, because it looks very nice, and a 3D end face view.
Floral.
Yeah.
Floral.
So that's only a trace MR from one side, and a normal pulmonary vein flow pattern, and clips which are nice and parallel.
Mario.
got it.
C3D.
Good.
One of the things I used to train with MitraClip is that take 15 minutes on the clip transeptal and only 5 minutes for steering.
We're deploying the clip.
Right.
Right.
Yeah. Grippers. Okay. All right. Okay. Both clips deployed. Looks very stable.
It's just that I don't like the orientation. I would prefer them, they would have been parallel to each other, but that's okay.
I know, but,
Yeah,
but
they
it was
were-
very difficult. The first one, we had to do independent grasping, just to try to get enough insertion.
No, it's okay. I mean,
Because the
at
heart
the end of the
rate
day,
actually-
you got a good result.
Well, let's
Yeah,
see
the
the
heart rate was
final.
very hard to
Let's see
control,
the
you saw
final T
earlier.
echo, and
Can we see the
I'd also
final
like
echo?
to see the left atrial pressure waveform.
I'll hold it.
Yeah.
Not even that, we have to show them the tracing, cleavages, right?
That's really nice. That's very good.
Barely, it's 0 to trace.
It's great,
That's
great
very
result.
That's really terrific.
Unfortunately,
there's-
Eberhard Grube left because I wanted to tell him, because he's a non-believer in MitraClip and he was smiling at me, and I wanted him to show you that it actually works.
Well, you can send. We'll send him
You
the
can
pictures
send him a
video
video
afterwards.
of and
This is such a beautiful picture of
Yeah.
showing. Can you show this picture of such a nice tissue bridge between the two? And as
please.
Greg mentioned in his talk, that
Keep flashing.
this is the best way
Keep
we
flashing.
coapt leaflets together.
Keep flashing. Keep flashing.
What was your gradient post clip?
Yeah, let's
Okay, stop flashing now.
That's
see
great.
Three.
this.
3.
Okay. Pressure.
Beautiful.
What's the map now?
The nice
Thank
paper
you.
would show
And
that
we can show
a
the
little bit of
pressure
gradient does
tracing.
make a difference.
Clips look parallel by echo.
Yep.
No, it's
so
okay.
the V waves actually have gone
Wow,
down.
look at that. Look at that.
Oh, that's beautiful.
That's beautiful. Just very small V waves. That's beautiful result.
Also, Greg, digoxin worked. Then we gave a cardizam. Everything brought the
Digoxin worked.
heart rate
60-year-old drug.
Yeah.
Still has a role. That's great.
Okay, we're gonna remove the guy from the septum now. Let's take a look at let's just look at the ASD.
Yeah, let's see the SD, yeah.
Okay, we're gonna remove the
Next,
guy now. It's back on the right atrium now.
Okay.
Okay, this is the right atrial pressure.
So you have two puncture
Not
sites
bad.
actually.
You have
One,
two,
yeah, two.
two-
Yeah.
yeah. Now you can
You
see,
see them.
one or the other. Yep. Yeah.
It's okay. I mean, you should follow them, and may have to close one of them.
Yes.
Because
Yes.
what will happen is the cumulative shunt now will be a little bit larger, right?
Yeah. Yeah. Yeah.
Malcolm, what do you
If
think?
it's a
the shunt-
1.2 or 1.3, QPQS shunt, that
Left to right.
probably is beneficial. It's probably okay.
But Greg, now there's a combination of two. But
I know,
I
there could-
think
it could be.
I think it's okay. But
Either way.
Yeah.
that's
okay,
that's
great.
What do you
that's
think?
beautiful imaging.
Yeah, these are two.
The
Yeah.
good news is that they
Two,
didn't
Yeah.
tear into each other, so you're more likely
No,
to have
you're
them
right.
both heal.
They're both gonna heal.
Yeah.
These are
We'll follow up with them in 30 days.
the two.
Thank you.
Small.
Well, that's
ASDs.
terrific.
Small,
That's just
small
great.
jets. Yeah.
That was Kinney then
Okay.
Gilbert. That was really nice, and it's also good for teaching for the audience to know how important
Yeah.
the transeptal puncture was, right?
Yeah.
I think it also
Yes.
shows the
Great.
value of live cases and the help, that a panel, in constant communication with live sites can be. I think this was great, back and forth, and I think the patient benefited. So great case, Anu, Gilbert, Stam, everybody. Beautiful demonstration, wonderful result. Thank you.
So
Thank
this
you.
will be the conclusion of our live case.
So
and,
four
thank you,
incredible
everybody.
cases,
everybody.
Anu. Congratulations to you and
Yes.
your team. 4 very, very incredible cases. We started with a valve-in-valve. We did a small annulus and enrolled the patient in the SMART trial, showing the importance of prospective randomized clinical trials and how we can incorporate that in our clinical practice. A mitral clip that now you just treated this functional MR patient with almost obliteration of the entire mitral mitral regurgitation jet, and the V wave going away and the pressure's improving. And then lastly, the bicuspid, pseudo-bicuspid or bicuspid valve work that you did, really incredible. 4 amazing cases for the New York transcatheter valve. Thank you for the entire team at Mount Sinai and the work that you guys are doing. Thank you. Made us proud. Thank you.
Thank you. Bye-bye.
Bye-bye.
We're waiting for you here, Dr. Kinney.